Hello and welcome. Today we're going to talk about posterior urethral valves. In particular, we want to revise the presumed embryological origin of posterior urethral valves, the epidemiology, clinical features, associated complications, and then we'll end this talk by just revising the general management of boys with posterior urethral valves. We've known about posterior urethral valves since the 1800s. They're important for us to know because they're associated with the development of chronic kidney disease and end-stage kidney disease in about 50%, close to 50% of all boys with this condition. And in fact, one of the most common obstructive causes of chronic kidney disease are these posterior urethral valves. Furthermore, posterior urethral valves are the commonest cause of bladder outlet obstruction in boys or in the pediatric population. And then these posterior urethral valves are actually a congenital membrane that is present in the lumen of the proximal male urethra. On this slide, we're seeking to just remind ourselves of the embryological origin of the lower urinary tract. So we can see in the diagram on the left that the hindgut is dilated to form the cloaca. The floor of the cloaca, number 2, is formed by the cloacal membrane. By 6 weeks, there is a development of the urorectal septum, which grows towards the cloacal membrane and thereby divides the cloaca into 2 regions, the anal rectal region and the urogenital region ventrally. It is this urogenital region that will later develop into the bladder and most of the male urethra. Just of note is the fact that the urogenital sinus is in continuous communication with the allantois as well as the mesonephric duct. These diagrams are from the website that is shown at the bottom. A closer look at the diagram that was on the right shows us that the newly formed urogenital sinus can be divided into 3 regions. The most ventral or cephalic part or cranial part will give rise to the bladder, most of the bladder apart from the posterior part of the bladder, the trigone. The middle or pelvic part gives rise to the prostate, the prostatic membranous parts of the urethra, and then we have the caudal or phallic part from which the urethral plate will develop, giving rise to the bulbous part of the urethra. Remember, we talked about the fact that the most ventral part of the urogenital sinus gives rise to most of the bladder apart from the area of the trigone. And that is because the as the urogenital sinus begins to increase in size, the mesonephric duct and the ureteric duct, that's number 2 and number 3, become incorporated into the posterior part of the urogenital sinus and also undergo a sort of migration whereby the mesonephric duct sort of migrates medially and inferiorly and will later develop into the vas deferens as well as the ejaculatory ducts, whereas the ureteric ducts migrate laterally and superiorly and will later develop into the ureters. So in summary, we've said that the origin of the lower urinary tract is from the cloaca. Once the cloaca is divided by the urorectal septum, we have formation of the anorectum and then the urogenital sinus. And it is this urogenital sinus that gives rise to the bladder as well as most of the urethra. Such that in a normal male infant at birth, the urethra can be divided into 4 parts. The first part lies inferiorly to the urinary bladder and ends prior to the beginning of the prostate gland. That's known as the pre-prostatic urethra. Then we have the part of the urethra that is completely encompassed within the prostate gland, that is known as the prostatic urethra. The membranous urethra begins immediately outside the prostate and ends just prior to entering the bulb of the penis. And then we have the spongy urethra, which travels the entire length of the penis via the corpus spongiosum, and the distal part of this is composed of tissue of ectodermal origin, whereas the more distal parts are made up of tissue which is of endodermal origin. So that if we were to cut the urethra and have a look at the lumen of the urethra in the region of the prostatic urethra, we would find this diamond-shaped structure known as the verumontanum, and then those 2 openings for the ejaculatory duct. And then starting from the distal part of the verumontanum going towards the external sphincter, we have the urethral membranes, also known as the plica colliculi. Now, the reason I draw attention to this area is because this is where we would find the abnormal posterior urethral membrane, known as the posterior urethral valve. So what are some of the theories that have been advanced to explain the development of posterior urethral valves? One has to do with the abnormal integration of the mesonephric ducts as they migrate into the final position of the ejaculatory ducts in the posterior urethra. So the theory is that during normal migration, a special connective tissue surrounds the mesonephric duct, and this special connective tissue in the normal male urethra gives rise to the urethral membranes, or the plica colliculi. But in posterior urethral valves, you get this sheath developing arising from this connective tissue and attaching to the entire circumference of the urethra. The second is that it could be arrested growth, whereby we get no apoptosis occurring in the region between the bladder neck and the verumontanum, and this then leads to a membrane in that region. And then finally, there are theories that say that it's a failure of resolution of the urogenital membrane that gives rise to the development of posterior urethral valves. So to recap, we're saying that there's abnormal integration of the mesonephric duct into the posterior part of the urethra, and this gives rise to an abnormal membrane in the region of the plica colliculi, shown in red in the illustration on the left. If we were to cut the penile shaft in a longitudinal view, you can see that oblique membrane of the posterior urethral valve in that position. So historically, various researchers or doctors have tried to classify or describe posterior urethral valves. We had mentioned the fact that Mogagni in the 18th century was the first to do this. In about 1918-1919, Young et al. Studied 12 children who had demised from posterior urethral valve related complications, and they came up with an anatomical description of posterior urethral valves. So type 1 posterior urethral valves, and the commonest type of posterior urethral valves, where they described a membrane in the anterior aspect of the distal verumontanum attached to the anterior urethra. The next most common type of posterior urethral valve is the type 3 type, and this involves development of a membrane that is attached to the entire circumference of the urethra with a central opening. And then finally, the rarest type, which involves where the membrane originates from the proximal verumontanum towards the bladder neck and internal sphincter. Now, there have been various critics when it comes to this classification system, and I think the biggest objection that was raised was the fact that the configuration of the membrane may just have been a result of prior instrumentation in the urethra of these children that had demised. So we then come to the epidemiology of posterior urethral valves. Incidence may range between 1 in 3,800 to 1 in 8,000 boys. It's important to remember that fetuses with severe posterior urethral valves tend to demise, and so this may be an underestimation of the actual incidence. In one series that followed up patients for about 18 years, 35% of children were diagnosed antenatally, whereas 42% were diagnosed in infancy and 23% were a late diagnosis. Now, obviously, in regions and healthcare systems where anomaly scanning is well established, more and more children are now being picked up antenatally. Posterior urethral valves can present either antenatally or postnatally, as mentioned earlier. So for antenatal diagnosis, this involves use of ultrasonography, so usually during the anomaly scan, and what may be reported is an over-distended bladder, also known as a megacystitis. The bladder walls may be thickened. There may be hydronephrosis, either unilateral or bilateral, and there may also be a report of oligohydramnios. So one study looked at the sensitivity of antenatal ultrasound to detect posterior urethral valves presence postnatally, and the sensitivity was reported as 94%, but the specificity was low at 43%. One key feature that may be present during antenatal scanning is what is known as the keyhole sign. This involves the presence of a distended bladder with a distended proximal urethra. So, as we said, specificity is quite low, and there are other entities that can lead to this keyhole sign appearing on ultrasonography. When the diagnosis of posterior urethral valves is made antenatally, the ultrasonographer can also report on some parameters that can give an idea on the prognosis for the fetus. The presence of oligohydramnios, especially in the first half of pregnancy, is a poor prognostic sign. If there are signs of increased renal echogenicity, cysts, or a perinephric urinoma, those are also considered to be poor prognostic markers. So For such fetuses that are diagnosed antenatally, what are the options in terms of management? Most parts of the world cannot offer much for a diagnosis that is made before 24 weeks, because the prognosis is really bad. For fetuses or pregnancies between 24 and 34 weeks, there are options for fetal intervention, but these are offered in only specialized centers. So one option is to try and divert urine from the bladder into the amniotic sac by doing what is known as a vesical amniotic shunt. And then the other option for mid-trimester pregnancies that are affected would be, for example, to do fetal endoscopic ablation of the valves. Now, before these interventions are offered, the doctors need to make sure that the fetus has a normal karyotype and that there is a good likelihood that the patient will have normal or good renal outcomes. So what do they use to determine or to prognosticate in terms of renal output? They aspirate some of the fetal urine from the fetal bladder and measure parameters such as sodium, which if it's less than 100 millimoles per liter, or chloride of less than 90, or if the osmolarity is less than 210, or if the total protein and the beta-2 microglobulin fall below established thresholds, then they would consider prognosis for good renal outcome to be good, and they would then consider intervening. But these parameters, there have been some studies that have shown that they may not be so accurate at predicting renal outcome. Beyond 34 weeks, if oligohydramnios is present, the mother is prepared for early delivery, things like maturation of the lungs, so that if it's deemed to be, if the intrauterine environment is deemed to be too dangerous for the baby, then the mother will be delivered. The postnatal presentation of posterior urethral valves ranges from mild to very severe. So for those fetuses that may not have been diagnosed antenatally, you may end up with a baby who is born with severe manifestations of that hostile intrauterine environment. So then these are children that are born with Porter's sequence. So because of the severe oligohydramnios, these babies are squashed in the mother's uterus and end up with contractures. Because of the limited amniotic fluid, there's limited lung development, they end up with lung hypoplasia and may have a respiratory distress at birth. And then also the characteristic Porter's fasces, which is marked by low-set ears, microganthia, and prominent infraorbital folds. Other features that may suggest posterior urethral valves is the presence of urosepsis. So infants that are admitted with neonatal sepsis are investigated and by conducting a sepsis screen found to have urinary tract infection, and if a scan is done, they may then be diagnosed, they may be found to have thickened bladder, hydronephrosis, and a diagnosis of posterior urethral valves considered. You may have infants presenting with acute urinary retention. Older infants, there may be a report of a poor urine stream, dribbling, hesitancy. You may have children that come in with recurrent urinary tract infections, and so posterior urethral valves can be detected upon investigation for repeated urinary tract infections. And then For some children, they may come in with severe renal failure in as early as in infancy. So they'll come in with features of renal failure, whether it be fluid overload, uremia, acidosis, and then for those who have gone on to go into chronic kidney disease, may have poor growth, bone abnormalities, so your rickets, they may have chronic anemia. It's also important to remember that because of the abnormal pressures to which the developing kidney and urinary tubes have been exposed to, patients may also present with tubulopathy. So you may end up with poor concentrating ability, so patient polyuric. You may end up with excessive sodium losses. Some children may even develop a type 4 renal tubular acidosis marked by the presence of acidosis and hyperkalemia. Investigations that would be done for suspected child with suspected posterior urethral valves obviously depend on the presentation of the child. So for those that are coming in septic or in severe renal failure, their condition would sort of determine the investigations that ought to be done. But in general, one would do a full blood count, urea, check their electrolytes, creatinine, a blood gas may be indicated, send off urine for culture and sensitivity, chest x-ray, and then to demonstrate the presence of the hydronephrosis, the bladder wall thickening, kidney ureter bladder ultrasound, and then to confirm the diagnosis, one would do a micturating cystourethrogram, but only if the child does not have active infection, if the child is stable. Otherwise, this investigation would be deferred. Later on, differential renal function would be done using nuclear medicine, in particular MAG3. Later on, uroflow and urodynamics may become necessary. On the right is a picture of posterior urethral valves demonstrated by a micturating cystourethrogram, and you can see that we have another keyhole sign there with dilatation of the bladder and dilatation of the proximal urethra or the posterior urethra, with a singeing in of the urethra demonstrating the actual valve. Management of posterior urethral valves involves firstly the ABCs. So you stabilize whatever may be of urgent concern, if it's the airway, if the patient has a problem with their circulation. After that, the next priority is to institute immediate bladder drainage. In the short term, this would involve catheterization of the urethra using, if possible, a Foley's catheter, otherwise a size 6 feeding tube in infants. If none of these options work, then one must arrange for a suprapubic tap with the urologist. Once you establish bladder drainage, please watch out for post-obstruction diuresis and electrolyte abnormalities which need to be managed. Patient may also present with other complications associated with posterior urethral valves, things like renal failure with associated anemia, acidosis, or infection. And so these then will also have to be dealt with. Give antibiotics, decide whether dialysis is necessary. Is it necessary to give replace electrolyte losses? Do we need to manage a hyperkalemia, for instance? But the definitive treatment of posterior urethral valves is endoscopic valve ablation in theater by the urologist, if they can find a scope that's small enough for them to use. In some low resource settings where it may be a problem to get pediatric endoscopes to accomplish the ablation, some have reported the use or progressively larger caliber Foley's catheter. In a situation where ablation is not immediately available, one must remember to maintain the bladder drainage, and in our setting, most of the time we prefer to go with the vesicostomy done by either the pediatric surgeons or the urologists. The other option, of course, is to long-term keeping a Foley's catheter, but obviously that comes with the risk of recurrent infections in the patient. Guidelines for long-term follow-up of patients. Our aims are to optimize the growth and development of the child. We want to keep an eye on the renal function of the child, and we want to monitor the bladder function. We want to prevent urinary tract infections. Although at present we do not have official guidelines, what we do practice is that as soon as a child is ablated, we tend to send them to urology after 1 month for a relook cystoscopy, just to make sure that there's no residual valve, so that the urologist can decide if the child needs a reablation. In terms of how often these children are seen in clinic, depends on how stable the child is, whether there are concerns. Obviously, if there are concerns, these kids are seen more often, but for stable children, generally monthly until the age of 6 months, and then 3 monthly until the age of 1 year. After that, 6 monthly. That's for stable patients. And during these reviews, we get a history of how good the urine strib is, history or physical evidence of urinary tract infections as a way of preserving the upper tracts in terms of function. We monitor for development of bladder dysfunction. We do ultrasonography to measure the residual bladder volumes and the epidiameter to monitor the upper tracts. Obviously, we do U&Es, creatinine, and full blood count. And in addition, we make sure that the other child health activities are also taken care of, so your immunization and nutrition. We, as I say, do not have official Zambian guidelines yet, but based on Indian guidelines, they recommend that differential renal function by doing a MAG3 be done at 3 months, at 1 year, 3, 5, 10, and 15 years. And then urodynamics must be done when the patient shows bladder symptoms, things like incontinence and so on. So we have a patient who has undergone ablation. It's important to remember as we follow up these children that this is not the end of the problem. The upper tracts, the bladder have been exposed to these abnormally high pressures, and so even post relief of the bladder outlet obstruction, there'll still be problems. One possible complication could be that despite the ablation, despite reablation and the second look, you may have patients who have persistent hydronephrosis, which may even be associated with a deterioration in renal function. So it's important to just check for possibility of vesico-ureteric reflux or a vesico-ureteric junction obstruction. So for the vesico-ureteric junction obstruction, particularly like in infants, they have this hypertrophied bladder wall, and that hypertrophy may cause the vesico-ureteric junction obstruction. And if these issues are not dealt with, they may lead to worsening of the renal failure. A child may keep coming in with recurrent UTIs. So then, one would perform an MCUG and decide exactly what's going on. some of the options, like if the patient has an overactive bladder, poorly compliant, would be medical management using anticholinergics such as oxybutynin, or in situations where one perhaps may be dealing with an atonic bladder, to ask for introduction of clean intermittent catheterization. And then, as all these problems are dealt with, it's also important to make sure that this child is seen jointly with urology regarding possible surgical intervention. So we said that one of the possibilities of persistent hydronephrosis may have to do with the presence of like a persistent valve obstruction. So one way in which we could check for that is to like do a uroflow and ultrasound. So in that kind of a situation, you may find that the residual bladder volume would be still high, so greater than 20% of total bladder capacity, and the uroflow pattern would support an anatomical obstruction. So you would get, instead of this bell-shaped normal flow pattern, one would get this flattened out curve. Other problems that may be encountered in these children that have undergone ablation are long-term complications. For example, renal failure, which we had mentioned earlier. So, for example, in a study that followed up boys that had posterior urethral valves for 18 years, just over 50% of them were found to have chronic kidney disease. Almost 40% had hypertension, 30% had bladder dysfunction, and there was also evidence of sexual dysfunction and reduced fertility. So looking after patients with posterior urethral valves is, one must, it's a long-term thing, and it shouldn't happen that once a patient undergoes ablation, then they get discharged. So we can begin with the renal failure, and as I mentioned, just over 50% of all boys with posterior urethral valves will end up with CKD, and up to 20% will have end-stage renal disease requiring renal replacement therapy. So why do they get renal failure? Essentially, it's because of obstruction to the urinary tract, which happens in utero, and this leads to distension of the urinary tract. And this triggers molecular mechanisms that result in activation of apoptosis of tubular cells, which leads to tubular atrophy. And there are various cytokines and growth factors and oxidative stress and inflammation and the renin-angiotensin system that modulate all these processes. So you have a condition where you have increased stretch because of obstruction, and then this leads to production of cytokines such as tumor necrosis factor alpha that activate caspase that leads to tubular apoptosis. Other cytokines such as tumor transforming growth factor beta may be activated because of the activation of the renin-angiotensin system. And then other molecules such as the epithelial growth factor, insulin growth factor, when present in high amounts, may actually prevent activation of this of the caspases, and therefore inhibit development of tubular apoptosis and tubular atrophy. Bladder dysfunction occurs in may occur in up to a third of boys who were diagnosed with posterior urethral valves. some of the problems that they may have are things like a high post-void residual volume. They may end up with a bladder which has low capacity but hypertonic, especially in infancy, and then this sort of changes to a compliant high capacity bladder but which poorly contracts, so is atonic. And then a few may have, an almost normal bladder. So the pattern of bladder dysfunction may change from infancy to adolescence, and this means that throughout follow-up of such patients, measures must be taken to always monitor changes in bladder function, look out for features in bladder dysfunction that may lead to a deterioration in upper tract function. So one pattern that I mentioned may be of the valve bladder dysfunction may be detrusor overactivity or hypercontractility, and this would be seen on a urodynamic study. What options are available? On the right is an illustration or a simplification of a proper urodynamics pattern. So in terms of the floor, you would see these tall curves, and then it's not really shown, but you would see overactivity of the detrusor muscle on the urodynamic printout. So what can be done for such patients? You can try medical therapy with anticholinergics or alpha blockers. One could try clean intermittent catheterization, botulinum toxin injections, and in extreme cases, the urologist may attempt bladder augmentation. The other pattern that we mentioned are patients that may have normal detrusor contractility but with low compliance. One could try timed voiding, for example. Then for atonic bladder, clean intermittent catheterization and overnight catheterization, and other methods, surgical methods of urinary diversion. So to recap, we said that posterior urethral valves may occur in up to 1 in 4,000 live male births. These valves develop because of disordered migration of the mesonephric duct into the posterior urethra or disordered apoptosis involving the proximal urethra. Diagnosis may be made either antenatally or postnatally. Of priority postnatally is bladder drainage using either a catheter, a feeding tube, or where these do not work, involve the urologist for a suprapubic drainage. We talked about the fact that definitive treatment is endoscopic ablation, where this cannot be done immediately because of lack or non-availability of appropriately sized scopes. An alternative for long-term drainage, such as a vesicostomy or a long-term catheter, should be found. And finally, we talked about the fact that despite treatment by ablation, problems such as vesicoureteric reflux, vesicoureteric obstruction, renal failure, hypertension, and the valve bladder syndrome may occur. And so long-term multidisciplinary follow-up is necessary. This would include the pediatrician, the urologist, the pediatric surgeons, and the nephrologist. Thank you so much for listening. If there are any questions, please you can place them in the comments section. Thanks.